All right, let's get started. So now we're going to look at the diseases of the tubules and interstitium, and then we're going to go back to lecture 14 to nephrolithiasis. We're kind of skipping. We're going out of order. All right, diseases of the tubule and interstitium. So there's three parts of the kidney that can be involved in renal failure. So the glomeruli, tubules, and the interstitium. So let's look at ATN. Now, this is going to be the most common cause of renal failure. It's going to be a rapid reduction in renal function and urine output, falling within 24 hours to less than 400 cc's a day. Like 100% you have to know this. So normal urine output is 1,200 to 1,500 cc's, but this is falling less than 400. So ATI, ATN, same thing. It's going to have injury to the epithelial cells with abnormal ion transport, and then increased delivery of salt to the macula densa, resulting into tubuloglomerular feedback, and then cast formation with necrosis and sloughing of the renal tubulars cells into the lumen. It's going to result in increased interstitial pressure and decreased perfusion. So let's look at this. So here's our tubule. We're going to have that sloughing off with that obstruction, and we're causing that cast. So let's look at the cast. It's that dark colored cast. And with the necrosis and tubular injury, the glomeruli are going to be normal. There's going to be a rupture of tubular basement membrane, and then there's going to be cellular cast, and it's going to contain a sonophilic hyaline cast or pigmented granular cast, and can have some renal tubular cell cast, which mostly consist of TAM horsepower protein. So these cells are like circles that are perfect circles. These are going to be like renal cells. Here's our little lines. It's probably like E. coli bacteria. This is going to be some epithelial cells that have been like sloughed off. This cell is going to be a white blood cell. Okay, toxic ATN is going to be our favorite ethylene glycol poisoning, which is found in antifreeze, and it's going to have marketed ballooning or hydropic or vascular degeneration with calcium oxalate crystals present. So we can see right here. Muric chloride is going to have really large acidophilic inclusion in the injured cell. So clinical course, it has 3 stages. We've got initiation, which is going to have slight decrease in the output and a rise in our BUN. Maintenance is going to be a urine output between 40 to 400. Salt, water overload, high BUN, and other abnormalities. And then recovery is going to be a steady increase in urine volume, up to 3 liters a day, because now our tubules are going to be recovering, and there's going to be sodium, potassium, water loss. So we first start out with a slight decline, then we go to like super low urine output, and then we go to high urine output. Okay, so tubulointerstitial nephritis includes pyelonephritis, UTI, obstructive uropathy, drug-induced analgesic nephropathy, and papillary necrosis, plus urate nephropathy and nephrolithiasis. Okay, so we've got tubular function defects, include the inability to concentrate urine, salt wasting, and decreased ability to excrete acids. Acute pyelonephritis is going to be a UTI that has now spread up the ureters into the kidneys. It's known as an ascending infection because we start at the bladder and we go up. And this is a way that can cause the patient to become septic. So like that's the next step. Like they got a UTI, now they got pyelo, now they're septic. Diabetes mellitus is a huge cause because they're immunocompromised and they've got high sugar and it's damaging the nerves. And then also, like if they're peeing out a bunch of sugar, like bacteria like to eat. So they're having like a feast on that sugar in the urine. So symptoms, fever, CBA tenderness. So like you tap on their back, and they're tender. They like jump off that table. Dysuria, so painful urination. Increased frequency and increased urgency. You'll see pyuria, so white blood cells in the urine, and then white blood cell cast. Mostly caused by gram-negative bugs like E. coli, Proteus, and Klebsiella. Remember, white blood cell cast we can also see in nephritic syndrome. And then with healing, it causes chronic inflammation and scars. So here's our pathway to get to that infection, which we've talked about. So microscopically looking at pyelo, it's going to be hypercellular, and there's going to be lots of neutrophils. So look at those neutrophils, remember, that are like right here, that dark nucleus. Okay, complications, papillary necrosis. So the tips of the distal 2/3 of the pyramids are going to have that gray, white, yellow necrosis. With that's coag necrosis, it's usually due to a urinary tract obstruction or diabetes. Another complication is pyelonephrosis. So total obstruction with pus filling, or a perinephritic abscess. Chronic pyelo is associated with reflux, and it usually involves the calyces and the renal pelvis. So a cause of this is going to be reflux nephropathy. So it's going to be in a kid with chronic infection. So here's an example right here. And so we can see that the chronic, they've got this blunted calyces, which has a scar. So we see dilation and blunting. Remember, like back from histo, what like the thyroid looked like. So it's not that like there's thyroid tissue here, but there's going to be thyroidation of the tubules because of the like the big sections of like pink. Xanthomatous pyelonephritis is going to be associated with Proteus infections and obstruction. And it kind of makes a like neoplasm looking thing. Obstructive uropathy is going to have a hydronephrosis with atrophy. And it's going to include continued glomerular filtration, which goes back into the renal interstitium and tissues and lymphatics. And so it's going to impair perfusion. So we can see that in these pictures. Okay, drug-induced tubulonephritis. This is really important. They can have that type 1, which is that IgE sensitivity, or type 4 T cell. And they're going to have eosinophils, like obviously, with our, since it's drug-induced and it's like almost like an allergic reaction. It's associated with penicillins, rifampin, diuretics, and NSAIDs. They act like haptens binding to component of the tubular cell and become immunogenic. Drug-induced tubulo-interstitial nephritis is going to have eosinophils, and then some drugs may have the non-necrosing granulomas, and then tubulitis is going to be that infiltration of the tubes by lymphocytes. And we can kind of see that here. And looking at this, we can see that those areas of papillary necrosis. So the prognosis in analgesic nephropathy is going to be chronic renal failure. And a small percent may develop into transitional papillary carcinoma of the renal pelvis. So urate nephropathy, there's going to be 3 types: acute uric acid, gout, and nephrolithiasis. So acute crystals, acute uric acid nephropathy is going to have that precipitation of uric acid crystals due to that acidic pH in the renal tubules. Our gout is going to be another cause of our chronic urate nephropathy. So there's going to be that deposition of the monosodium urate crystals in the tubules, and histology, birefringent needle-like crystals with a like tophus reaction. So here's like our tophus. Okay, nephrolithiasis and hyperuricemia. We've got uric acid stones, and more than half of the patients with these stones don't have any hyperuricemia or increased uric acid in the urine. And these stones may be from a too low urine pH. Hyperuricosuric calcium nephrolithiasis is going to be that nucleation of the calcium oxalate crystals by the uric acid crystals. The uric acid stones are going to be radiolucent, and if you look at them under the microscope, they look like little footballs or little lemons. I kind of think of them as, I don't know, I always thought of them as little lemons because lemons are acidic. Okay, multiple myeloma. We've got light chains called Bence-Jones proteins. And if you get a question about SPEP, it tests for IG in your urine, looking for these gamma-globulins and looking for these Bence-Jones proteins. So here we are looking at this with our light chain nephropathy cast. So these are kind of like easy to point out. They look really different than other things. Okay, let's look at nephrolithiasis. So we've got, here's some terms to know. I'm just going to skip right past that. Our epidemiology, there's a high recurrence rate, so you need to think about secondary prevention. Honestly, like, know the definition of secondary prevention. It is, I know it seems sort of silly, but like that's our screening yearly exams. So like getting a lipid, getting a pap smear, that's a screening exam, that's secondary prevention. So know that. Okay, the third most common renal disease is going to be nephrolithiasis. After UTIs and prostate disease, we've got different types of stones: calcium oxalate, phosphate, uric acid, struvite, cysteine, and others. So here's our presentation of a patient. They're going to have flank pain, hematuria. They pretty much can like crawl up a wall. Female patients who've had children before say that kidney stones hurt worse than having a kid. You're going to do a urine analysis looking for hematuria. You're going to do a non-contrast CT, make sure it's non-contrast because you won't see it if it has contrast. Maybe a renal ultrasound, like plus or minus. And then once they pass the stone, you can do a stone analysis and it can help figure out how to prevent them in the future. So how do these things happen? Well, our kidneys filter out our blood. If there's too much of something, there's going to be crystal formation. Here's our pain location. Kidneys. Here it is. They don't really hurt in the kidneys, but like they may have like CVA tenderness, but like all the way down here, they're gonna have pain. Okay. Here's some pictures. Like you don't really need to know these pictures, but still. So calcium oxalate, a monohydrate. This is what our like antifreeze looks like when you see it in the urine. Also, it like lights up, which is pretty exciting and scary. This envelope shape, which I think looks more like a princess cut diamond, but they call it envelope. They're really pretty and shiny under the microscope. And that's what these look like. The important one to know is our calcium phosphate. And they look like a, it says like wedge-shaped prism, or like rosettes. And they're going to have high calcium, low citrate, and high urine pH. I probably know that. And they've got distal renal tubular acidosis, and or like drugs with a carbonic anhydrase inhibition. Coffin shape is our struvite crystals. They're also called triple phosphate, and they've got high levels of ammonium and bicarb. Uric acid, here's our little lemons. See, looks like a lemon. And then cysteine is going to be like a hexagon shape. This is what I used to do before med school, like look at people's urine, run labs. It's kind of fun. Okay, so there's 3 ways a stone can develop. On top of a plaque, so which is called Renal's plaque, which is our calcium oxalate stone in the tube. That's our calcium phosphate stone. And then within the interstitium, that's our cysteine stones. Here is our Renal's plaque. Remember that's calcium oxalate. And see how you can see just like a plaque develop. It damages that renal tissue and allows that calcium phosphate to deposit. This happens in the renal papilla. And then, so what happens is we've got inside the tubule, we've got these renal tissue damage, calcium phosphate deposits. On top of that calcium phosphate, a calcium oxalate crystal develops, and that's that Renal's, on top of that Renal's plaque. You can see right here. So instinitis for calcium oxalate stones, and the plaque itself is made out of calcium phosphate, but the calcium oxalate sits on top. I know it's kind of confusing. So here's our calcium phosphate. And then here's our calcium phosphate. Sorry, let's do it this way. And then our calcium oxalate, our calcium phosphate, which is our Renal's plaque. Our calcium oxalate is going to be sitting on top of it. Calcium phosphate Our urine pH is going to be high because phosphate is going to bind to hydrogen. They kind of look like pom-poms, phosphate pom-poms. Calcium oxalate is going to have too much calcium being excreted. So in the blood, it's going to be hypocalcemia, or too much oxalate being excreted. And then hyperoxaluria is much stronger renal stone promoter. So I would 100% know that. What is calcium oxalate caused by? Big oxalate, lots of oxalate. So risk factors, we got a lot. Hypercalciuria is high calcium in our urine. We're getting rid of a lot of calcium. Is a risk factor or promoter. Remember, most common for oxalate is going to be low levels of oxalate, or I mean high levels of oxalate go into our urine. Hypercalciuria is getting rid of over 200 milligrams per day. If it's idiopathic hypercalciuria, it's going to have a normal serum calcium and PTH. High oxalate, low calcium diet causes increased oxalate absorption. So make sure that you eat a lot of calcium. So you've got these calcium oxalate stones, increased dietary calcium. Citrate, low citrate is going to be an identifiable risk for that calcium stone formation, and then magnesium is going to be an inhibitor. So distal renal tubular acidosis type 1 forms a alkaline urine, so greater than 5.5 pH, and it's going to have a calcium phosphate stone formation. Uric acid stone, they're excreting too much uric acid. And they're going to have a low pH. So uric acid, lemon, acidic. Struvite stones are going to be associated with chronic UTIs, and it's more common in women, and it requires, in those people who require frequent catheterization, it can cause that staghorn calculi, like right here, you can see, looks like horns. And they've got the coffin lid shaped crystals. They're also called magnesium ammonium phosphate stones. Oh, and like little side note, quick side note, like you are not going to hear staghorn, or I mean struvite ever like on the lab. Like they don't learn the word struvite, so like out in clinic one day, you're not going to see that word probably. I'll probably say triple phosphate. Radiologic evidence. We're not going to image every patient, but those that are like crawling the wall, they've got fever, infection, pregnancy, history of disease, then we'll do a scan. Non-contrast CT is great. Can't do that with pregnant people, so right here we can see a dilated ureter, and right here we can see a stone. I mean, they're bright white. And here's some stones coming down. So you probably like see a CT on this test. These are like the easiest to find. You just see like, what is that white dot? Is that a tooth? No, it's a stone. If it's like a kidney, we don't care. It's not going to bother them, but once it's like lower down, we do. This is a huge, massive hydronephrosis. So you can think about how this is like deforming everything. So it's obstructing and it's causing backup. Cystine stones are going to be caused by autosomal recessive mutations in the SLC3A1 and SLC7A9 involved in amino acid transport. The median age is going to be an onset of 12. In the vignette, it'll talk about a child. They're going to be hexagon-shaped crystals. Okay, initial treatment, we're going to try to like wash that right out of here. So we're going to give them IV fluids and help them with pain. Ketorolac actually helps because it's the NSAID. It helps better than opiates because it's going to decrease inflammation. Another thing that will be given is that might be given is like azocin. So also known as like Flomax, the brand name, to help them pass it. If it's big, they may have to surgically remove it. Okay, secondary prevention is when we look at the stone, we can try to come up with some approaches. So for all types of stones, increase urine, so we pee them out. For potassium citrate, alkalize the urine. You might have to dietary changes. Don't restrict calcium anymore. Citrate supplementation with citrate stones. Thiazides can help. Xanthine oxidase inhibitors like allopurinol for the uric acid stones. And then a UTI treatment. Okay. So here's just looking at the stuff again. Promoting and inhibiting factors. All right. So that one is done. So we're on to our last one. This one's like shorter, which is good. All right. 18 and 19, we've got our congenital acquired pediatric renal urological disease. Okay, this one is a little bit of a rough lecture, I'll just be honest. And these questions will probably be weird. And I mean, the lecture I think is weird. And the questions will literally come out of nowhere. So I'll try to remember and help you, but no promises. Okay. And probably a lot of these will be dropped. So here we go. Congenital and acquired diseases. Common congenital diseases are the posterior urethral valves and ARPD, PKD, acquired IgA nephropathy, and membranoproliferative glomerulonephritis. Okay, it's posterior urethral valves are the most common cause of lower UTIs in neonates. You know, usually boys don't get UTIs, but there was like a 17-year-old boy that I saw one time in clinic that like he would constantly get UTIs, and he told us that his kidneys and ureters were shaped different. And I think he didn't know, like he didn't say what it was, but I'm sure this is what he had, was the posterior urethral valve. He was like before med school, so I didn't know about this stuff. A urine prenatal ultrasound will show hydronephrosis, and then a child will have another ultrasound right before birth. Before that, it was only found if they had a UTI. So PUV path, it's present by week 4, obstructing membranous folds, and so we can see it right here. Clinically, they may have that, if it's both sides, they'll have that Potter's facies, limb deformities, small chest cavity, ascites, pulmonary problems, hypoplasia. Labs, in the first 24 hours, the labs are going to be the same as mom. You need to look at the BUN and creatinine, and you have to report it in 1 week. You'll do a voiding cystourography, where dye is placed in the bladder and looked at, and then cystoscopy, where they look in it with camera. So first time they use a catheter to relieve the bladder, and then valve ablation is going to be performed. Complications is going to be UTI with bedwetting. You need to treat the UTI first. Remember, we've already talked about this. ARPKD, we've talked about autosomal dominant adults. It's a flank mass in infancy, and then or with autosomal recessive, it's going to be flank masses and Potter syndrome. Here is the recessive type. Again, looks like little tubes. Here's the comparison again, just to review. Berger disease, which is different than Berger disease. Which Berger disease is the vascularity, where it's a smoker and then their like fingertips and toes turn black. That's Berger. This is Berger, so it's pediatric IgA nephropathy. We've talked about IgA nephropathy. It's going to be associated with an upper respiratory infection, not strep. So like a month ago, I had a URI and I got over it. And now I've got painless hematuria with protein in my urine. The kidney biopsy is going to be diagnostic and confirmatory. Ultrasound can be used to detect abnormalities, but not confirm. So confirmation comes from a biopsy. IgA is going to be deposited in the mesangium, and there's going to be clinical gross or microscopic hematuria. Here's looking at that light microscopy. Remember, it's in the mesangium. We've got this like dark eosinophilic shading, and then on immunofluorescence, we've got this mesangial deposits. So you can see the little deposits. Okay, membranoproliferative glomerular nephritis. There's going to be 3 subtypes, and it's going to be prognosis will be the presence of hypertension and chronic nephrotic syndrome. MPGN is going to be like we had talked about before. This is like looking back, like reviewing. It's favoring, there's type 1 and type 2 immune complexes, and type 1, type 2 favors the C3 activation. We've got stabilization of the alternative pathway. So remember, it's that C3 nephritic factor in that dense deposit disease. That was type 2. Looking at it, we've got the tram track formation, and then we've also got the lobules. Type 1 subendothelial dense deposit disease, type 2, is going to be ribbon-like. So, type 1 subendothelial, it's that dark stuff, REM, and ribbon-like for dense deposit disease. Treatment is going to be maybe ACE inhibitor and a diuretic for type 1, and then type 2 needs to be checked for hepatitis B or C or infective endocarditis. Okay. Last one, congenital and acquired pediatric renal urological disease. Okay, so male track. So embryologically, until week 8, the fetus looks the same, whether it's a male or a female. The Wolffian structures become internal male genitalia, and the Mullerian duct becomes internal female genitalia. So Dr. Dudzik said, like, wolf, like, I don't know, sounds more like a man. Kind of like stereotypical, but that's what she said, but if it helps you remember it. And then maybe like mom Mullerian, you know. External genitalia starts changing at 12 to 16 weeks, so that's why they see the sex of the baby at like 16 weeks. The genital tubercle becomes the penis, and the labroscrotal folds become the scrotum. Okay, this is super important. We have hypospadias, and this is where it is an anterior urethral development defect, and there's going to be an opening on the ventral side of the penis. Remember that like ventral versus dorsal, you have to think of like the anatomical position, which would be erect. So that is going to be on the ventral side, which would be like the back of the tiny guy. So that's going to occur within weeks 8 to 20, and it's going to be failure of the fusion of the urethral folds, and it may be genetic. So let's just go to the next one. So, but if we look at it, it's like right here. Epispadias, we will probably cover in a second. Epispadias is on the posterior side or dorsal side. Okay, hypospadias. If you suspect an infant boy has a type of hypospadias, do not do circumcision. And then if they're with torsion, if there's any symptoms like pain, fever, erythema, at any age, get ultrasound examination of the scrotum so they don't lose it. Okay, hydrocele is going to be a collection of fluid in the scrotal sac. There's going to be communicating, non-communicating, and ones of the spermatic cord. And the diagnosis is going to be transillumination. So the patient has no pain, and the swelling is not acute. You can make the diagnosis of hydrocele. It usually resolves in the first 2 years, and treatment's just observation. So like it might ask you about, you know, mom's concerned about that baby boy's scrotum's really large. Take a flashlight, you can see through it. What's the treatment? And the treatment would be observation, reassurance. Okay, hydrocele. Communicating hydroceles are going to be caused by a failed closure of the process vaginalis at the internal ring. Crypto, which we had already talked about. So cryptorchidism is going to be failure of the testes to descend. So the part that is scary about this is the risk of testicular cancer is going to be almost 10 times higher than normal men. So why in the world would this matter? So the testes are very sensitive. They have to be at the correct temperature. So if a testes hadn't descended and it was up within the abdomen, it's going to be warmer than if it was in the scrotum. So that warmth could cause that malignancy rate to increase. Always do a testicular exam. And if it's not repaired, the child could be eventually, when they're an adult, infertile. And the treatment is orchiopexy. That's what the surgery is called. So you're looking at cryptorchidism. So here's an abdominal. I mean, I really wouldn't worry about that patient. Okay. This one I think that she really liked. Phimosis and paraphimosis. So phimosis is going to be congenital or acquired. So this is non-circumcised men. So they're unable to retract the distal prepuce over the glans penis. And so a lot of times it's not that they don't clean it well. And it causes like irritation in a fibrotic ring. And so the tissue closes over the opening. So if it completely closes and obstructs the urinary stream, there's pain, there's blood, like that's a problem, obviously. But otherwise it's not. Paraphimosis, which para around, is going to be entrapment of retracted foreskin. So they retract their foreskin, I guess to pee or whatever, then can't get it back down. So if you think about it, like, let's say you've got a ring on your finger and you're trying to get it off, and you try and you try and you try, and it starts like swelling and being red, and they have to like remove it. Same thing with this. Paraphimosis is the entrapment of that retracted skin behind the penile corona. It's an emergency. So make sure that you know paraphimosis, emergency, phimosis, not. That's men. Let's look at females. Females, like mom mullerian, it happens week 9. And they're going to, the ovaries are going to develop into the genital tubercle and to the clitoris and the labioscrotal folds. Don't fuse. You can have a persistent sinus and cloaca, and that's going to be a severe defect that involves the urinary tract. It can have a simple sinus or sinus with anorectal malformations, and if they fail to migrate. And you can see this on the genitogram. Urethral prolapse is pretty uncommon, but it's where the distal urethra goes through the external meatus. So kids that have, it's more common in like older women. It's not as common in kids. So if kids like strain too hard with constipation, they'll present with blood in their diapers and no history of trauma. And there's just a poor attachment between the smooth muscle layers. So the treatment for this is going to either be a sitz baths or estrogen cream in severe surgery. Vaginal atresia is going to be a congenital defect of the uterovaginal outflow obstruction due to problems with the Mullerian ductal system genesis. So teratogens may be a cause of this. It's usually not detected until puberty. Vaginal atresia was common with a medication that moms took in the 1950s. It had been taken off the market, and their child would end up with vaginal atresia. So they're going to present with amenorrhea and abdominal pain, and you'll go over this more like when you get to reproductive class. So, but still need to know some of it now. Primary goals are going to relieve the pain and obstruction. So this girl has abdominal pain, and normal secondary characteristics. But look at their like huge uterus and no vagina. And here's looking at it again. Labial adhesions are really common. They're not really symptomatic though. It's usually found when like parents are changing diapers. Kids just get irritated, being like warm, moist continuously, especially due to like just being in diapers and irritation, rashes, all that. So sometimes they'll have dysuria and adhesions will be visible. Always look at the external genitalia through the first year of life. Treatment is going to be similar to the urethral prolapse, and it's going to be topical estrogen cream. Surgical separation rarely needed. All right, guys, that is it. That is all of it. Does anyone have any questions? All right, well, just feel free to message me, email me, anything if you have any questions before, after, whatever, your exam. And good luck.